smaller venue than the years before.
Yeah. Cozier.
Cozier, more intimate.
It's nice. Well, good afternoon, everybody, and welcome. We'll get started as the last few people grab a little lunch and take their seats. My name is Alan Cockle, and I direct health programs at the Pew Charitable Trusts. We are a nonprofit organization that work on issues of public importance in a wide range of issues in American life and internationally. And we've been actively engaged on the issue of antibiotic resistance for a number of years. And I'm happy to welcome you on behalf of Super Moms Against Superbugs, which is an advocacy initiative of ours that brings together not just moms, but parents of all flavors and doctors and farmers and others to share their experience and expertise on this important issue. Today's briefing is co-hosted by a number of organizations. I want to thank them and acknowledge them. First of all, the CDC for being here. I'll say more about that momentarily. But also the American Academy of Pediatrics, the American Medical Association, Healthcare Without Harm, the Infectious Diseases Society of America, Keep Antibiotics Working, the March of Dimes, the Milken Institute, School of Public Health, and Trusts for America's Health. All of these organizations have worked on this issue for a number of years. And in fact, people have been talking about antimicrobial resistance for decades. In fact, when Fleming received the Nobel Prize for the discovery of penicillin, he warned that if we use the drug indiscriminately, the bugs will become resistant to it and the drugs will lose their power. And now we find ourselves in 2015 at what is really a critical juncture for this issue. People have been talking about it for a long time, and as we'll hear from Dr. Frieden shortly, we now face more resistance, a greater threat than we've ever faced. At the same time, we've never had more focus by the government and by healthcare and by all kinds of stakeholders and sectors to really tackle this problem and make a meaningful difference. So let me give you a quick rundown of the day. Dr. Frieden will make some opening remarks, and then we will introduce our four panelists who will each share their story and their experience with you, and then we will have lots of time for question and answer. So it's my great pleasure and honor now to welcome and introduce Dr. Tom Frieden. He is, of course, the director of the Centers for Disease Control and Prevention, which has long been a national leader in this fight, and Dr. Frieden himself, an infectious disease doc, this is an issue that is especially close to his heart. So Dr. Frieden, thank you for making the trip. You have arrived fresh from the airport. You almost didn't make it, and we're delighted to have you here. But would you please take it away?
Thanks very much, Alan. Thanks to Pew for hosting this event, along with many co-sponsors whose work we really value and whose partnership is essential for progress in this and so many other areas. I also particularly want to thank all of the super moms and super dads, super parents who've taken time out of their lives to help others so that we can ensure that our kids have the miracle drugs that we've come to take for granted. I especially want to thank Everly Macario for being here with us and sharing her story. We know that personal stories are often the most powerful way to motivate change, and we've seen that in many different fields. I am an infectious disease physician by training, and one of the reasons I went into infectious diseases is that it's so satisfying to have a patient come in feeling terrible and be able to give miracle drugs and see them arise from the bed and go home safe and sound. And yet I've watched in recent years with increasing concern and fear as we lose some of our most powerful drugs. Josh Lederberg said many years ago, it's really a race, our brains against their numbers in terms of the bacteria. And so the question is, will we have the wisdom and foresight to use these miracle drugs well and carefully so that we can make sure that they're available for us, for our kids, and for our grandkids when we need them? Antibiotic resistance is so frightening, not just because there are bad infections that you can get, a skin infection, a pneumonia, urinary tract infection, and that's bad enough. But the fact is, we rely on antibiotics to treat what are common complications of routine medical procedures, ranging from cancer chemotherapy, which 600,000 Americans per year go through, to organ transplantation, to treatment for arthritis. So if we lose the ability to treat infections reliably, we risk undermining much of modern medicine. Each year, we estimate at CDC that at least 2 million Americans get an infection with a drug-resistant organism, and at least 23,000 die. In addition, about 15,000 Americans die from an organism called C. difficile, which is a result of antibiotic use. One of the things that we have to get better at in our society is balancing risks and benefits, short-term and long-term benefits. The risks of antibiotics for a patient who doesn't have bacterial illness will outweigh the benefits of those antibiotics. For many years, physicians might say, well, I know they may not have an infection, but I'll better be safe than sorry. I'm going to use an antibiotic. And yet that resulted not only in the spread of drug resistance, risking that patient's life, but also the rise of C. difficile, 500,000 C. difficile infections a year in the US. So we now understand that there's an alignment between the interests of the individual patient and the interests of society and community at large. And that's a good thing, because we can all work together to address a serious problem. Preserving antibiotics is absolutely essential. There are actions that all of us can take to better preserve antibiotics, and that includes, from the health department standpoint, tracking, preventing outbreaks, stopping outbreaks when they occur. It includes, from the prescriber's standpoint, making sure that prescriptions are rational to the greatest extent possible. We have an estimate that between a third and a half of all antibiotics prescribed in the U.S. are either entirely unnecessary or overly broad and therefore unnecessarily risky. There are new drugs in development, and we're cheering them on, and we want them to come to the market quickly, but we also recognize that we will not invent our way out of this problem, at least not for the next decade. We recognize it takes a long time to bring a new antibiotic to the market, that virtually all antibiotics are outsmarted by some bacteria once they come out onto the market, so that some bacteria will become resistant. So we need, at the same time, we're encouraged by and want to see accelerated drug discovery, we can't rely on it, both because we don't know what will happen and because if we don't preserve and improve the way we use antibiotics today, then the new antibiotics that come online will also be compromised soon after they're released onto the market. And we've seen this with newer drugs. In fact, in 1991, I wrote an article on the widespread inappropriate use of oral ciprofloxacin, and now we're seeing ciprofloxacin and quinolone resistance across a wide range of pathogens. Patient safety is a critical concept for us all to pay attention to. This isn't about denying patients effective treatment, quite the contrary. This is about protecting patients from harms that are avoidable, whether it's C. diff or drug-resistant bacteria. And we know that this can be done. In parts of the U.S. where we've worked collaboratively with healthcare facilities and others, we've seen dramatic decreases in the deadliest bacteria, CRE, or carbapenem-resistant Enterobacter, down by 60% in just a few years in the Chicago area with intensive intervention. Partners are key here. We're honored to be the federal agency in charge with promoting antibiotic stewardship, and we take that responsibility seriously. This year's Get Smart Antibiotics Week included a presidential proclamation. WHO is doing similar things on an international front. There was a very exciting stewardship forum at the White House last June with more than 150 commitments, serious commitments from all parts of the society to do more to preserve antibiotics. Pew Charitable Trusts, as well as clinical experts, are helping, I think, in very important ways. We're working with many different healthcare systems to try to track and increase the rational use of antibiotics so we can have some indicator of how we're doing. If we measure things in real time and accurately, we'll be able to improve them more rapidly. CMS has been working to ensure that stewardship programs in hospitals are a core feature. And if you look on a website, we can see what proportion of all hospitals in each state have stewardship programs. And it's right now quite variable across the country and quite variable within states. So we want consumers, providers, healthcare administrators, policymakers to pay attention to what we need to do to protect people and to protect and preserve antibiotics. We also work very closely with both the USDA and the FDA. We have a tight partnership to track possible outbreaks, and not just to stop those outbreaks, but to learn from each of them to try to prevent similar outbreaks from happening in the future. Funding is essential. This year, the administration asked for a $264 million increase in our budget to fight drug resistance. The House, Mark, proposed $120 million. The Senate proposed $30 million. We hope that we'll end up somewhere between 120 and 264 in the next couple of weeks, preferably quite close to the original ask, because it's not just about money, it's primarily about lives. We estimate that over a 5-year period, that investment will can prevent more than 600,000 infections with drug-resistant bacteria, more than 37,000 deaths from drug-resistant bacteria, and nearly $8 billion in healthcare expenditures. There's a terrific return on investment for it, but we need to see that investment made or we won't be able to protect patients and preserve antibiotics. And of course, it's a global effort as well, and I'll end just with a comment on the importance of this globally. We know that emerging resistance anywhere can potentially spread to other places, though we're seeing most of the deadliest organisms here homegrown. But early in my career, I treated tuberculosis and lots of multi-drug resistant tuberculosis. I treated a man from Kerala, India, who had what we would now call extremely drug-resistant tuberculosis for about 2 years. We had to remove part of his lung. His wife, who was a nurse, had to give him injections with injectable antibiotic for about a year. And after what cost more than $100,000 at that time, and this was a long time ago, would cost 3 or 4 times that now, he was cured. A few years later, I moved to India, where I worked on tuberculosis control, and if we had just put the programs in sooner to improve rational antibiotic use, make sure patients take them, have accountable systems, stop outbreaks, we could have prevented his $100,000 near-fatal case of tuberculosis for $10. Thank you very much.
Thank you for setting up really great remarks, setting up the conversation today. And, you know, a number of things that Dr. Frieden mentioned. One is going to CDC's website and looking at how many hospitals and healthcare systems have stewardship programs, and they should all have them. And it's somewhat astonishing in this day and age that they don't yet all have them. And one of the things that looks like it will happen soon is that Medicare, as a requirement of participation in Medicare, will require hospitals to have stewardship programs to ensure that the drugs aren't overused. And then people will look to say, well, what's a meaningful stewardship program? How do we do it well? And CDC has developed core elements of those programs and resources for healthcare institutions to use, to draw on, to say, how do we construct these things in a way that's successful? One of the things that you mentioned that we're excited about is a partnership between Pew and CDC to do a lot of analysis of very detailed data on antibiotic use. As we all know, if you want to make progress against a problem, you have to be able to measure it and track progress. And so Pew has partnered with the CDC, and CDC scientists have been analyzing data on antibiotic use in the outpatient setting, looking at in adults with sinusitis in this part of the country, how many prescriptions are there, and how many are there in this part of the country? And by doing that, and doing that in the outpatient setting and the inpatient setting, we'll be able to set really detailed targets for tackling this problem. As Dr. Frieden mentioned, the president has made this issue a priority, and across the government there's been real momentum for tackling it. And on the agriculture side, and we'll talk a little more about this today, but just also an important part of the equation, the use of antibiotics purely to make animals grow faster is being phased out. The FDA has asked, and the companies have agreed to withdraw their growth promotion indications for use of antibiotics in agriculture. But there's still a lot we don't know about how the drugs are used, what drugs are used in what quantities for what purpose. And FDA and USDA are moving forward with a plan to collect that data so that we can get a better understanding of what drugs are we using for what purposes and what quantity, and which way is the trend line running. It's also exciting that the private market is beginning to change. And just in the past year, we've seen announcements from Walmart and from Costco and fast food chains like McDonald's, Chick-fil-A, which was a little more than a year ago, I think, Panera, and also big producers of chicken like Tyson and Purdue, all moving towards production of meat with less use of antibiotics. And if you're interested in learning more about that, we have a fact sheet just outside that details some of those commitments. And that's not an exhaustive list that I just gave now. So that's exciting. And then finally, as Dr. Frieden said, we need new drugs, but it takes time to innovate new drugs. And the bad news is there's not much in the pipeline. And so there were 29 new antibiotics that reached the US market in the 1980s. There were 23 in the 90s and 9 in the first decade of this century. And we have, Pew has an analysis on our website of everything that's in clinical testing, anywhere from early to late testing. And there's not much there. And even more worrisome, there's not much there that's really new. What's there tends to be variations on drugs that were discovered more than 30 years ago. So we really do need innovation, and we need innovation on diagnostics. And there has been action in this space too. Congress passed the GAIN Act a couple of years ago, which provides some additional economic incentive for developers of antibiotics. And Congress is now looking at legislation that passed the House and is being discussed in the Senate to create a special approval mechanism for drugs that really address the public health needs. So this is called a limited population approval for drugs for very resistant infections, which would also create a more streamlined pathway for companies to bring these drugs to market. So there's a lot going on. And with that, let me turn to the rest of our panel to share their stories, and then we'll open up the discussion. So I'm really pleased today to be able to welcome Everly Macario, who's here from Illinois. She is co-founder of the MRSA Research Center. Probably everybody knows MRSA is also MRSA is a resistant form of bacteria that is quite common, and she is a spokesperson for Super Moms Against Superbugs, which I mentioned earlier. It's this advocacy coalition. To her right is Scott Wiseman, a pediatric infectious disease doctor and medical director of the Antimicrobial Stewardship Program at Seattle Children's Hospital. Will Harris, here from Bluffton, Georgia, is the owner of White Oak Pastures, which is a family farm raising a wide range of food animals using sustainable practices. And as we'll hear, it's a big family farm and a very interesting story. And finally, Aparna Boal, also an infectious disease doctor, representing the American Academy of Pediatrics, and with us from University Hospitals in Cleveland, Ohio. So I'd like to welcome all of the panelists, and Everly, would you lead us off?
Sure. Good afternoon. First of all, I just want to say I'm so pleased that this room is full. I think that really reflects increased awareness of this critical public health issue. So thank you so much for coming, and I really hope that when you leave here that you'll act on everything that we have to present. And Alan and Dr. Frieden did an amazing job painting the scientific picture and also the market forces. And I'm here to really drive home what's at stake. So I'm here as an example of the real and destructive effects of antibiotic resistance. My husband and I experienced every parent's worst nightmare. On April 16th, 2004, our son, Simon Sparrow, woke up with a terrified scream and a fever. My husband took Simon to the emergency room at the University of Chicago Medical Center at 7:30 in the morning. The doctors ran the standard battery of tests, including a chest x-ray and an oxygen level test, only to speculate that Simon may be an asthmatic kid. When I joined Jim, my husband, and Simon at the emergency room about an hour later, Simon was sleeping on my husband's lap, looking so angelic. The reddish tint from his blondish hair glowed in such a way that it made me think there was a halo surrounding his beautiful cherub-like face. He seemed so peaceful and content in his daddy's lap. I felt relieved. Simon and I stayed in the emergency room until about 1 p.m. Given how irritable he was, I could tell something was really wrong. He truly was inconsolable. When my husband returned to get us, he noticed Simon's lips were blue as we walked out of the emergency room doors. We went back in and pointed this out to the doctors. They, once again, measured his oxygen level and informed us that he was within normal range. We went home and gave Simon albuterol via an inhaler. At about 4:30 p.m. that afternoon, I called the doctor to tell her that Simon's cheeks were cold and to have her hear Simon's very labored breathing, and she told me to call 911 immediately. Before I knew it, the ambulance arrived. The EMTs applied an oxygen mask to Simon's face and brought him to the ambulance. I noticed how uncharacteristically limp Simon was in one of the ambulance crew team's members' arms. Simon would normally have been trying to wiggle out of a stranger's arms and would have been screaming for me, and he wasn't doing that. In the ambulance, they performed the oxygen level test, only to inform me once again that his oxygen level was fine. As soon as Simon was wheeled into the emergency room, doctors hooked him up to everything imaginable: oxygen, nebulizer, IVs for medication, and pain relievers. He had tubes coming out all over him. And I kept hearing all the medical personnel saying repeatedly, "Your child is very, very sick. Your child is very, very sick." Simon was brought to the ICU, where he was intubated to help him breathe and given a broad spectrum antibiotic to attempt to counteract Simon's infection. A couple of hours later, the attending physician said that they had to get Simon on an ECMO machine, which stands for extracorporeal membrane oxygenation, or the heart-lung machine, or basically life support. And this was his quote-unquote only chance. On April 17th, 2004, late morning, that was just the next day, Simon was pronounced dead without a precise cause of death. An autopsy revealed that Simon had contracted an antibiotic-resistant bacterium, which was something that I had never heard of. Dr. Frieden mentioned it, MRSA, M-R-S-A, methicillin-resistant Staphylococcus aureus. And it was specifically a new strain of MRSA. It was the community-associated MRSA strain, not the more likely healthcare-associated strain, and that this strain was a superbug. At that time, I had never heard of MRSA, and this astonishes everyone that I know because I have a doctorate from the Harvard School of Public Health. Since then, I joined infectious disease experts to help found the MRSA Research Center at the University of Chicago Medical Center to address the exaggerated demand for antibiotics by patients and the tendency to overprescribe antibiotics among doctors. 2/3 of infectious disease doctors have treated patients with infections that did not respond to any antibiotics, and half of antibiotic use among humans is unnecessary or inappropriate. Antibiotics are a precious gift that should only be used as a last resort, not to treat most colds, the flu, or other viral infections, or in the routine use of low doses to healthy food animals. Indeed, overuse of antibiotics in human healthcare and on farms is the perfect recipe for antibiotic resistance and for assuring we enter a post-antibiotic era. And I want to repeat that term, post-antibiotic era. And another new learning for me along my journey was that 70% of all antibiotics sold in the United States are sold for purposes for use among food animals. So that was completely new to me as well. Imagine a world where we can no longer rely on antibiotics. Life would look like what it was like in the early 20th century before Alexander Fleming discovered penicillin. I got a window into that world when I witnessed my own toddler son die in my arms. Let's not return to that world again. The less we rely on antibiotics, the better antibiotics will work when we so desperately need them. Thank you.
I really thank you for once again sharing your story. It's so powerful and such a reminder of why we're here. Scott, you deal with this from the clinician's point of view every day. Would you talk about your perspective on this?
Sure. In 2006, I was asked to consult on a young woman who had been born with a condition called bladder exstrophy, where her bladder was not fully enclosed at birth. She had had dozens of surgeries in her 20 years to provide her with normal functioning and quality of life. Throughout her life, she had experienced far more urinary tract infections than other children her age and had received more than her fair share of antibiotics to treat them, but was being referred to me as the expert because her bacteria had become increasingly difficult to treat. I looked at her susceptibility test results for her bacterial infections, the reports that came from the lab, and took a deep breath and rolled up my sleeves and tried to figure out how I was going to do something that the many physicians she had already seen weren't able to do. For the next 3 years, we struggled to get these infections under control, but had really only very brief periods of symptom-free health for her before the infection would return, showing up as stomach pain, back pain, headache, fatigue. And this really had a serious impact on her quality of life and really on her mental health. We tried antibiotics by mouth. We tried antibiotics by IV. We tried antibiotics as an injection into the muscle. We even tried antibiotics being infused directly into her bladder. We tried antibiotics one at a time, and we tried them in combination. We tried probiotics, cranberry juice, and a full array of alternative therapies that I had to learn about as we went. This patient taught me a lot of what I now know about managing infections due to multi-drug resistant bacteria in complicated patients. And I'm grateful to her for letting me join her on that journey, because it's a journey that I've had to take with many patients since. But being a specialist at an academic referral center, I didn't fully appreciate how this kind of antibiotic resistance, this multi-drug resistance, was changing medicine even for community providers and community pediatricians. What I learned during her care was that she was infected with an E. coli strain called sequence type 131, which is one of those license plate acronyms that microbiologists are so adept at. But this strain, ST131, was first described only in 2008. It really was something new under the sun. And by that point, it had already swept the globe, leaving a trail of destruction in its path. It was a single strain that reshaped the treatment of something that had been fairly routine, urinary tract infection, just as the community-associated MRSA strain USA 300 that Everly just told us about had done for skin and soft tissue infections. It took something that was routine and made it something that was no longer routine at all. So as patients like the one I described continued to appear and make their way to my clinic, it became clear that new approaches to managing them were needed. So complicated patients like this couldn't be managed just by one doctor at a time, then going to another specialist and sort of doing this ping-pong back and forth. So my colleagues in urology and I started a new clinic where we would join together to talk with patients and families about the very difficult challenges that they had been facing and were going to continue to face. And this really, for me, has become the model of care in the antibiotic resistance era. It takes a lot of time, it takes a lot of education, and it takes a lot of humility to say, I actually don't know what to do. I don't know if what we're going to try is going to work. And so on the basis of that honesty and trust, we negotiate a plan. How did we get here? How did we get to a place where both healthy children and complicated patients are coming across these nasty, vicious bacteria that weren't known when I completed my medical training? Well, according to excellent data from the Centers for Disease Control, for example, in Washington State, for every 10 residents, there are 6 antibiotic prescriptions a year. So approximately 1 in 2 people, on average, are getting a prescription for antibiotics in Washington State. And kids actually get quite a bit more than that. On average, kids receive at least 1 antibiotic prescription a year for their first decade. And if that sounds like a lot, consider that Washington State is one of the lowest in terms of prescribing rates in the 50 states. And for every 10 residents of the southern states, the southeastern states, the rate is double that of Washington State, some 12 prescriptions per person per year. Our current practice of medicine, as Dr. Frieden has said, in the United States, our current practice is built on the back of life-saving antibiotics. If these agents lose their therapeutic power, we'll be left with a healthcare system that we do not recognize and certainly would not accept. Not only will we lose the power to save lives with chemotherapy and bone marrow transplant, we will be unable to restore function and hope with procedures like cardiac bypass and joint replacement. And we'll lose the ability to treat what have become routine infections of the skin and bones in pediatric patients. What is routine will no longer be routine. And already, I see these nasty, vicious bacteria making previously healthy people sick and making treatments that used to be routine no longer routine. Preserving these agents requires a dramatic reassessment of our prescribing habits as physicians and our antibiotic consumption practices as parents and patients, and also of our relationship to food as consumers. Thank you.
Thank you. Scott, thank you for that. And I would love to come back and ask about some of the steps you've taken in your hospital to ensure that the drugs are not overused, but we'll come back to that. Right now, Will, would you tell us about White Oak Farm and the approach you've taken to the use of antibiotics in producing food animals?
I will. Honored to be here with you all today. White Oak Pastures is my family's farm in Bluffton, Georgia. My great-grandfather came there in 1866, and we've operated the farm continuously for 150 years. Between 1866 and 1945, my great-grandfather and grandfather operated the farm. And that would have been a farming system that was done without the tools that science gave us to increase production. It would have been a very high animal welfare system, a very environmentally sustainable production system. My father took over the farm post-World War II in 1946. And his generation really revolutionized agriculture. And it was done for very noble purposes. It was done to make food cheap and abundant and safe from the perspective you don't eat it and have an acute illness. And again, it was wildly successful. It did that. But there were unintended consequences. And these unintended consequences fell on the backs of the environment, the animals, and possibly human health. I went to the University of Georgia and farmed in the same way as my father. And I took the industrialization, commoditization, and centralization to a whole new level. And farmed like that for 20 years, and it was rewarding, and it was profitable. And I never one day felt like I was doing any harm to anyone or my land or my herd. I operated the farm as a monoculture of only cattle. I used all the industrial tools that reductionist science had given us. Pesticides, chemical fertilizers, GMOs, and performance-enhancing drugs to my animals. The farm was financially successful, but in the mid-90s, I was beginning to become disillusioned and maybe disgusted with the excesses of that production system, and I started taking the farm back to the system of the more high animal welfare, high environmentally sustainable system of my great-grandfather and grandfather. Today, we pasture raise and hand butcher 5 red meat species on the farm: cows, hogs, sheep, goats, rabbits. We pasture raise and hand butcher 5 poultry species on the farm: chickens, turkeys, geese, guineas, and ducks. We grow certified organic vegetables, pastured eggs, and operate a number of other ancillary businesses that would never survive on their own, but go to work in the organism that we consider white oak pastures to be. During the 150 years of the farm, it's gone from a farm to a factory and now back to the organism sort of system. We gave up using hormone implants, performance-enhancing drugs like antibiotics, antibiotics for the purpose of growth promoted and prophylactic use, pesticides, chemical fertilizers, and the other tools. During that window, the farm has gone from employing 3 employees, basically at minimum wage, to 120 employees, all of whom make well over minimum wage. It's been an economic boon for our community. We feel that we have made enormous strides in the regenerative kind of farming practices that has built our land and cleaned up our water. And we have herds and flocks that have no physical alterations to them whatsoever and enjoy expressing instinctive behavior every day. An example I'd like to give is, please understand, I am a farmer. I am not a medical doctor or a dietitian or a scientist of any sort. But I am an expert in animal welfare, environmental sustainability, and the economic impoverishment of rural America. Anecdotally, I'll give you an example of a resistance issue that I personally experienced. Of horn fly, I'm in the deep south. Horn flies and face flies are a very economically significant parasitic pest to cattle. Several years ago, there was an organophosphate infused ear tag that just absolutely did a fantastic job controlling horn flies and face flies. It lasted 1 year. After that, it didn't help a bit. Later on, there was a synthetic erythroid after the organophosphate. It lasted 1 year. So, I've personally seen resistance take what could be a great scientific tool from being highly efficacious to being worthless. So, thank you for having me here today.
Thank you for that. And let's go back now to healthcare. And Aparna Bol, would you share a perspective from your practice in your institution?
Sure, thank you. I appreciate the opportunity to share my story with the others up here today, and thank you for being here to be part of the discussion. I'm a general pediatrician at University Hospital's Rainbow Babies and Children's Hospital in Cleveland, Ohio, and I'm also the sustainability manager for University Hospital's health system, which is comprised of several community hospitals as well as ambulatory care centers across Northeast Ohio. In that capacity, my goal is to integrate environmental along with social and economic considerations into all of our operating practices. I'm also a member of the American Academy of Pediatrics Council on Environmental Health Executive Committee and a member of the board of Healthcare Without Harm, which is an international coalition of healthcare stakeholders working to implement alternatives to healthcare practices that pollute the environment and contribute to disease. So as both a pediatrician and a sustainability professional, I have experience with antibiotic stewardship in the realm of patient care and in the realm of institutional food purchasing, and I'd like to share a little bit about that with you. We understand, as you've heard a little bit from others up here, that infants and children bear a significant burden of antibiotic-resistant infections. We know that overuse and misuse of antimicrobial agents in both human and veterinary medicine is largely responsible for the emergence of antibiotic resistance. So the American Academy of Pediatrics, or the AAP, has a longstanding commitment to supporting antibiotic stewardship. As such, pediatricians are leading the way on promoting strict clinical criteria for antibiotic use in our patients. For example, the AAP has addressed a common context for antibiotic overuse in human medicine by establishing principles of judicious antibiotic prescribing for upper respiratory infections, or URIs, in pediatrics. These recommendations acknowledge the fact that when it's unclear whether URI represents an acute bacterial infection or a viral infection, the harms of antibiotic use outweigh the benefits. And as you've heard a little bit from Dr. Frieden and others, these harms are really not just to the public health in the form of increasing the prevalence of antibiotic-resistant organisms in the population, which is significant, but also unnecessary antibiotic use can directly harm our patients. I once cared for a 2-year-old boy who was given an antibiotic for what was likely a viral upper respiratory infection, and he developed a severe reaction to the drug called Stevens-Johnson syndrome, in which the top layer of the skin and mucous membranes dies and sloughs off. This condition can be life-threatening. For my young patient, whose Stevens-Johnson syndrome was caused by exposure to an unnecessarily prescribed antibiotic, he was admitted to the hospital, suffered from severe pain, and developed significant respiratory distress from swelling and sloughing of the mucosa of his mouth and throat. He required admission to the intensive care unit and weeks to fully recover. I would argue that even more common, milder adverse events associated with antibiotic use, such as diarrhea and rash and others, are unacceptable harms in the setting of unnecessary antibiotic prescription. As you've heard already today, the majority of antimicrobial agents sold in the United States are for animal use. Many of these are considered important for human medicine. Again, the AAP affirms the importance of judicious antibiotic use in animal agriculture. We released a technical report earlier this week called Non-Therapeutic Use of Antimicrobial Agents in Animal Agriculture, Implications for Pediatrics. There are copies out on the resource table that describes this issue for pediatricians. Because of this, we know that the increasing prevalence of antibiotic stewardship programs in children's hospitals and other healthcare organizations really should extend to our food purchasing practices. So beyond the prescribing practices, to include our food purchasing practices as institutions. Currently, sourcing meat that is produced without non-therapeutic antibiotics can be a challenge in our existing food system in this country. But the growing demand for antibiotic-free meat from the health sector is helping to transform our food system towards safer, healthier animal husbandry practices. Healthcare Without Harm has helped to aggregate demand for responsibly produced meat in the U.S. healthcare sector. Last month, nearly 300 healthcare facilities across the country celebrated Food Day by serving more than 235,000 meals that featured meat and poultry raised without the routine use of antibiotics. Several hospitals and health systems, including mine, university hospitals, have purchasing policies or resolutions in place specifying a goal to purchase meat produced without non-therapeutic antibiotics. That effort in our institution has allowed us to achieve from a starting point of nearly zero to about 20% of the meat that we purchase now being antibiotic-free in the space of just a couple of years. Our suppliers and our food distributors are hearing us. They're hearing us and our colleagues across the country who are engaged in similar efforts. Both judicious prescription and food purchasing practices, as well as sensible regulation of antibiotic overuse in animal agriculture, are essential to effective antibiotic stewardship, which is so critical to the goal of preserving the effectiveness of antibiotics for current and future generations. Thank you.
Thank you. So I'd like to thank all the panelists for their remarks, and I want to open it to questions. We have microphones in the room, and I'll ask you to do two things, please, because time is short and we want to get as many folks in as we can. So please keep your questions short, and also if you would identify yourself when you ask a question. And while we're getting the mics out, I'm going to take the moderator's prerogative to just quickly ask a couple of my own. And Dr. Frieden, I'll start with you. You talked about the importance of funding. The current budget request contains a request for additional funding for CDC. What would that enable you to do in the space of antibiotic resistance?
When we think about effective programs in public health, we think about finding problems when they first emerge, stopping them quickly, and preventing them wherever possible. And that's what this funding would allow in drug resistance. We would be able to find things faster by improving diagnostics, rapid susceptibility tests, networks to track around the country, epicenters where we'll learn more about it and intervene sooner. Stop it faster with programs like Detect and Protect, which work with hospitals to improve their management of drug-resistant bacteria, and most importantly, community-wide approaches such as those used in Chicago and elsewhere that can rapidly drive down the prevalence better than any one facility can do alone. Even the best facility in the world is powerless to stop this if the nursing home across the street or the doctor down the block isn't doing the right thing. So we need a community-wide approach to stop it. And finally, in prevention, primarily through better prescribing, but also through more rapid identification and stopping of antibiotic-resistant outbreaks. So we see, there are a lot of resistant cases, but we don't see behind the resistance pattern to the genomic pattern to say, they're actually all a cluster. They can be stopped if we find the source. So that core triad of find it, stop it, prevent it, not just in a few places, but in every state in the country.
Thank you. Will, let me go to you. You talked about all the species that you produce on your family farm. So quick two-part question. One is, I know you sell to Whole Foods. Who else do you sell to? And then, we consume a lot of meat in this country. Can meat be produced, at large scale without antibiotics?
Well, the second question first, can meat be produced at large scale in this country without prophylactic or performance enhancing antibiotics? Yes. I mean, we're doing it right now on my farm every day. We sell about $28 million worth of meat, red meat, poultry, and eggs per year. We sell to Whole Foods, Publix, Kroger, Giant Eagle, food service distributors like U.S. Foods, Cisco, a number of others, and mail order through our online store. So yes, it can be done. When we start talking about feed the world, what food production system can best feed the world, I think we've got to stipulate up front that no food production system can feed the world if we have exponential population growth in perpetuity. No system can. If it's dependent upon land only, the industrial factory farm system is the most efficient. But when you put other resources like water, petroleum, antibiotics, other limiting factors in, the other system falls down. The industrial commodity centralized system falls out much quicker than my system does.
Thank you for that. I have questions that I'd like to ask the other panelists too, but I also want to make sure that I get to the audience. So I know there's a question down here in front. So go ahead, please. Introduce
Stand
yourself.
up?
Whatever you like.
Sure, okay. Hi, everyone. My name is Vanessa Lammers. I'm here with the Public Health Foundation. I think some of our partners might be in this room. Thank you all for being here. This project is really dear to my heart. We previously did a antibiotic stewardship driver diagram where we tried to align healthcare and public health, and we're currently working with health departments to address antibiotic resistance and antibiotic stewardship. I'd love to hear from you any ideas of how health departments could help you, and any challenges that you've had so far. We'd like to really align healthcare and public health. So thank you all.
I think that's a great question for Dr. Frieden.
Well, health departments are critically important in this equation. In fact, just a month or so ago, we released an analysis of what could be done to reduce antibiotic resistance in a community. And if you have a coordinating function at the health department, bringing together doctors, pharmacies, hospitals, nursing homes, and others, you can get a much more rapid, sustained, and deeper reduction in drug resistance than individual activities. The challenge is that many health departments aren't funded for it, and that's why the funding that we've requested would go to support protection programs in every single state in the country to strengthen the health departments and their ability to do that. And that examples of where that's been done. We have visitors from the UK where they were able to drive down antibiotic prescribing and drive down C. diff by half in just a few years. So we know that there is progress possible here, but it's going to take concerted action, and often it will be the local or state health department that will be key to that action.
May I expand on that? So I think, as you said earlier, no single hospital can fight these problems on its own. We have a complex healthcare system. The ecology of the networks of acute care hospitals, of long-term acute care facilities, nursing homes, and so forth. It's a very complex ecology with patients that move from one to the other far more quickly than even the data about them and their infections can follow them in their electronic charts, if there even are electronic charts. And so, in a way, in the sense that every epidemic or plague exploits certain features of a system, it is our system of complex healthcare, of facilities that don't talk to one another necessarily very well, or certainly routinely at all, that makes the health department function absolutely essential as to provide that, to try and fill in those gaps through communication. And I agree that the funding to do that will help kind of raise the whole performance of the system at large, not of individual facilities, but of the whole system in aggregate. And I think it's critically important that we fund those functions.
It's a great question. Thank you, and appreciate you both for your answers. There's another question here.
Sure, Latasha Lee from Senator Brown's office. Thank you for organizing and presenting such a very timely briefing, especially with the WHO's recent release of some of the TB numbers, which I would hope Dr. Frieden could possibly elaborate on. I have a two-part question, first on TB and the multi-drug resistant forms. If you could kind of discuss that and what some of the strategy is behind some of the efforts by the CDC, as well as the long-awaited White House plan on TB. Additionally, we will be reintroducing the STAR Act. And I enjoyed your triad that you talked about, stop it, find it, prevent it. Can you talk more about the stop it and some of the lack of innovations that I think Alan kind of alluded to, with only 9 drugs in the pipeline, and what I guess industry or what government can do to kind of encourage that. As a former R&D person at Lilly, I know my infectious diseases division has kind of been scaled back.
So that was at least 3 questions, and I'm on all of your behalf, I'm watching the clock. So I'm going to invite Dr. Frieden to maybe pick one of those, and we can, if people can stick around after, maybe we can have a bit more discussion. But
in terms of tuberculosis, the first thing we have to do is make sure that patients with tuberculosis are fully treated, because a lot of the drug resistance arises because patients stop treatment early. So all the work we do to create new drugs or treat patients with drug-resistant bacteria will fail unless we stop programs that are generating drug-resistant tuberculosis. It's not possible to treat drug-resistant tuberculosis faster than a poorly performing program can create drug-resistant tuberculosis. And we're seeing that in countries, particularly with large private healthcare systems that are unregulated, that the drug combinations used are deeply irrational. But we also need to improve diagnosis, so we can diagnose it more quickly, not just one drug, but all of the drugs that are used, and tailor the treatment for the patient. And one of the other aspects of the new initiative that we're proposing is to do better diagnostics. It's not because doctors are mean that they're providing broad-spectrum antibiotics, because they don't know what patients have. If we had a test that could rapidly determine what the antibiotic resistance pattern was, we could then tailor that antibiotic. So innovations are important, not just for new drugs, which are very important, but also for new diagnostics.
thank you. And on the question of innovation, I'll just mention something quickly that I didn't mention earlier, but we have spent the past year bringing together discovery scientists from industry and from academia who have identified real unmet needs upstream of drug discovery, questions, basic science questions that haven't been addressed, that could really stimulate a new generation of drug discovery across a whole range of companies and stakeholders. And so with them, we've developed a scientific roadmap to kind of lay out the questions and a structure for how that might be tackled. And that's something we haven't released yet, but we think that can be a helpful contribution in terms of restarting the pipeline. We're past 1 o'clock, so I regretfully have to wind us up. I want to thank all of our panelists for really insightful and powerful remarks. I think they make the case that this is one of the pressing public health issues of our time. It's not too late to act, but we must act, and we are acting, and we thank you all for being here and for your work and for your support on this crucial issue.